All right, good morning, everybody. So a couple things I want to talk about before we get started. Another reminder that on Friday, before you all left for Mardi Gras break, I posted 2 lecture recordings online. And it was I think I put 19 and 20 in the little question, but it was chapters 18 and 20. And those are required. You do have to watch those. It was like a lecture and a half worth of material. It wasn't quite 2 lectures. And that is the rest of the makeup for the ice storm to kind of catch us back up so that we didn't miss it any days. So hopefully you've watched those. If you haven't watched them yet, it doesn't particularly matter. You can watch them in any order. It's not like last time where it's like, oh, we got to cover part 1 before we cover part 2. This you can kind of learn in any order. So if you haven't watched it yet, just make sure you watch it at some point before the test. So to reiterate our timeline, today we are going to be doing chapter 19. We should be getting all the way through chapter 19 today. And then on Monday, we are doing chapter 21. And then exam number 4 is on Wednesday. And I don't know that I've particularly said this out loud, but your exam number 4 is on Wednesday. The final exam for this class, which is an optional final, is the last Wednesday of class. What is that, March 2nd? So the optional final is March 2nd. If you do not want to take the final, you are done after you do exam number 4. You don't have to come to class on Friday. You don't have to come to the optional final. It's optional for a reason. So if you are completely happy with your grade after exam number 4, you are done. There's no lecture on Friday or anything like that. I will be in my office hours that whole day on Friday and Thursday. If you have questions, you can come look at your exams. I will get your exams posted and graded as quickly as possible. I know that there are some people that are like, well, I don't know if I want to take the optional final until I get my exam number 4 grade back. And I understand that, and I'm going to get them graded just as quickly as I possibly can. But yeah, so that optional final is Monday, March 2nd. It is optional. You do not have to take it. It is a comprehensive final, meaning that it will cover material from all 4 of the other exams in equal measure. It's 25% exam 1, 2, 3, and 4. Yeah. Again, that's optional. If you are happy with your grade after exam number 4, you don't ever have to come back here again. Okay, is there any questions about any of that? The timeline or anything? Okay, and if you don't know this, there is have somebody show you if you don't know how to do it, but there is an option in Canvas, like in your Canvas gradebook, you can type in numbers for like your exams, like what do I have to get on this optional final to get a B? And you can do that on your own. You can just go to your Canvas gradebook and type things in until you figure out which grade you need and things like that. Because there are some of you that taking the optional final is not going to increase your grade. Because the optional final, it replaces your lowest test score. And just as another reminder that if you do worse on your optional final than you did on any of your other 4 exams, it doesn't matter. That's the one that gets thrown out. So there's no risk to it other than you have to stay here until the last day class. That's the only downside. Yeah. Okay. All right, so we will be going over chapter 19 today. Remember again, you do have to watch chapters 18 and 20, the lecture videos posted last Friday. So you should be able to see the links, or if you're subscribe to my YouTube channel, they're all in there as well. I think that was it. Again, just make sure that you watch those videos. Those are required material. This isn't like my normal lecture recordings where I post it, and if you came, you don't have to watch it. You do have to watch it. It's required material. I recommend watching it sooner rather than later so you can ask me any questions you have. Come by my office hours or send me an email. Ask me anything that you are confused about. And last thing, before we get started lecturing, don't forget that you do have your Smart Book assignments that are due on Wednesday, the same day as your exam. The Smart Book assignments, there are 6 of them. Most of them are shorter than some of the past SmartBook assignments. I think a couple of them are only like 20 or 30 minutes long. So they're a fair bit shorter, but there are 6 of them. So plan accordingly because they are due next Wednesday. Okay, so today we are going to be lecturing about the respiratory system. So we're moving on to a different respiratory system. And the respiratory system has a couple of different parts. Again, there's a lot of information on the slide. I'm going to point out the stuff that you need to know about it. So your respiratory system is broken into 2 separate parts. We have the upper respiratory tract and the lower respiratory tract. The upper respiratory tract is basically everything in your head and neck. Okay, so that includes everything in your mouth and nose. It includes your sinuses and also your ear canals. We'll talk more about that in a minute. But everything connected inside your head and neck. A lot of people don't realize that your ears are connected to your throat. Again, we'll talk more about that in a second. But your ears are connected to your sinuses. They're connected to your nose, your throat, and they are also connected to, my goodness, I forgot the word, the trachea. I couldn't figure out which word I needed. Connected to the trachea. So the upper respiratory tract, again, is everything from the neck up. That's your upper respiratory tract. It's in the upper part of your body. The respiratory tract is mostly focused around getting oxygen into your body. So you need oxygen to run everything else in your body, run all of your muscles and your nervous system. The respiratory tract is how your body gets that oxygen. You breathe in, you breathe out. Okay? And then your lower respiratory tract is everything part of the respiratory tract from the lower neck down. So this mostly includes the lower trachea and your lungs. Now your lungs, they come down and they branch off, and we're not going to talk about all of these individual things. If you take anatomy, you got to remember all the parts. The biggest parts about the lungs that we're going to talk about are these alveoli. And the alveoli are the little tiny air sacs that are in your lungs. They're very, very tiny. You have trillions of them in each lung. And that is where oxygen exchange happens. So you breathe in the air, and that is where the oxygen goes into the alveoli, and that's how it gets into your blood. And that's also how your blood drops off carbon dioxide as a waste product. Okay, so those alveoli are really important for oxygen exchange. Now, in terms of normal flora, your respiratory tract does have a lot of normal flora. We're not going to talk specifics about specific types or anything like that, but it is important to note that your respiratory tract does have a fair bit of normal flora. Most of it is not sterile or even close to it. You tend to have the most normal flora near the openings. So that should make sense that you have the most bacteria living where your body is exposed to the outside world. So your nose and your mouth. And the further you move away from your nose and mouth, the less normal flora you have. So your mouth and nose and upper throat have tons and tons and tons of normal flora. There are trillions of bacterial cells living inside your mouth. It's a petri dish in there, okay? But the farther you get away from your nose and mouth, so into your sinus cavities and then down into your lungs, the less normal flora you have. So your alveoli, for example, which is all the way down at the bottom of your lungs, are going to have very, very, very little, if any, normal flora. So the most normal flora closest to the openings, your mouth and nose, and less normal flora as you get away from that. Okay, and then I wanted to zoom in a little bit on the ear canals because a lot of people don't really think about the ears as being a part of the respiratory tract because your ears don't really have much to do with oxygen exchange, which is what the respiratory tract is known for. However, it is a part of the system and it is physically attached. So your ear canal, your ear in general, can be broken into 2 parts. You have an outer ear, which is the part you can stick your finger in, right? It's the outer part. It's the part that touches your skin. It's the outer part. It's the part that touches the outside of the body. And then all of this is the inner ear. And the outer ear and the inner ear are separated by an eardrum. Okay, so the eardrum is at the back of your outer ear canal, and it's what separates the outside from the inside. Now, the eardrum, for the most part, if it is intact, is not a penetrable membrane. So things cannot typically, if the eardrum is intact, are not going to get into your inner ear from the outside. Okay, so things are not going to get into your ear from out here and penetrate past that eardrum. Okay, but the inner ear has all of the bones that make it possible for you to hear and all that fun stuff. But the part that we're concerned about the most is this part right here called the eustachian tube. And I have another picture of this in a minute. But the eustachian tube is a tube that connects your inner ear to basically the back of your throat. So you have a tube that goes from the inside of your ear, kind of back here, and it goes down and drains into the back of your throat, kind of behind your tonsils, near your tonsils, kind of way back here. Okay, and there's a tube, and the reason for that is because your immune system and your body is constantly producing fluid in your ears. There's supposed to be immune cells and red blood cells and things like that that get pushed into that ear, and then it all is supposed to drain out of that tube. Okay? And it's supposed to drain into that tube and go down your throat where all of the rest of that stuff is dealt with, just like the mucus in your mouth and nose. Okay, so that is called a eustachian tube. And we're going to talk more about that in a minute, but I wanted to bring up the anatomy of it first. That is the eustachian tube. All right, so our first infection that we are going to talk about is called acute otitis media. Now, acute means, just in general, it means quick, a fast, or quick infection. Something that's acute is something that is a rapid onset, it happens quickly, and it's over quickly. Most of the infections or diseases that you're going to have in your life are going to be acute. You are going to be sick for a couple of days, and then you will get better, fast or quick. Otitis media is just a fancy name, and you do have to know both, but it's a fancy name for an inner ear infection. So not an infection on the outside. An infection on the outside is something completely different. This is the inside of your ear, so behind the eardrum. There's a couple of normal causative organisms of this. Streptococcus pneumoniae and Haemophilus influenza are both bacteria. And then a lot of different viruses can cause it. We're not going to talk about any in specific, but a lot of those cold viruses, flu viruses, any kind of virus that infects your respiratory system can also infect your inner ear. But Streptococcus pneumoniae and Haemophilus influenza are two big bacteria that cause otitis media, or an inner ear infection. And this is what the major symptoms of an inner ear infection look like. So this is a normal eardrum. Notice that it's kind of fleshy colored. It's like a pale tan. And if you look real closely, if you're good at this, you can actually tell that you can see through this eardrum. So this is the eardrum right here. And if you look really closely, you can actually see through it. So that's a bone right there, that kind of dark spot. And if you're really, really talented at this and you've looked at inside a lot of ears, you can pick out all the other features. But the important thing to note here is that you can see through it. Okay? So that is a normal eardrum. And this is what doctors are looking for when they stick that thing in your ear with the little flashlight on it. So they're looking at your eardrum. And this is an infected eardrum. Notice all the redness, first of all. This right here is pus. And then notice there's redness all around the ear canal. And what you might not be able to tell at first, but when I point it out, hopefully you can see it, is that this eardrum is actually broken. So this person's, the membrane that was originally over here covering the bones is now broken. There's no membrane covering that anymore. So the eardrum has done what we call perforated, which means it's got a hole in it. Okay, so what acute otitis media is it's a buildup of mucus and pus and infection in the inner ear. It's a buildup of mucus, infection, pus in that eustachian tube and in that inner ear, which can put pressure on the eardrum. So the most common signs and symptoms of this are pain in the ear and fever. If the infection gets bad enough or it goes on long enough, it can cause a perforation in the eardrum because the pressure behind that membrane will be enough to make it pop. Okay, which sounds really dramatic and it sounds like it would be a huge issue, but this is, I think we've talked about it before, but when my son was little, he was one of those kids that had infections in his ears every other day, it felt like. And he hasn't had an infection in a long time, or he hasn't had regular infections in a long time, ever since he got his adenoids removed. But every once in a while, he will get an ear infection. And even to this day, because he had so many infections, every time he gets an ear infection, his eardrums perforate in both ears. It's just a common thing that happens, and it sounds really dramatic, and the first time his doctor told me that was happening, I thought he was not gonna be able to hear again. It's just not that serious. Your eardrum will grow back, but his eardrums are weak because it's happened so many times. And so anytime he has an infection, the eardrums do perforate. Something that's just kind of a tip if you ever experience this or ever have kids, is that if a kid is complaining of their ear hurting, and you think that they might have an ear infection, and then all of a sudden they're like, oh no, it feels better. Like it just feels better now. I don't know what happened, but it like popped and now it feels better. That's because their eardrum perforated. So when the eardrum perforates, it releases the pressure and it doesn't hurt anymore. It's like, this is gross, but I feel like most people have an experience with this. But like you have like a really bad zit and it really hurts, and then you pop it, it feels better, right? It's kind of like that. It pops the pressure, and so it doesn't hurt anymore. So transmission and or prevention of acute otitis media. Acute otitis media is most often from endogenous bacteria. So this is bacteria that already exists within the respiratory system. So Streptococcus pneumonia and Haemophilus influenza are both, I'm going to put NRF here. That means normal respiratory flora. Normal respiratory flora, NRF. So Streptococcus pneumonia and Haemophilus influenza are bacteria that exist in the mouth and nose of most normal humans. It's part of our normal respiratory flora. The reason that it's able to cause infections and why it does cause infections sometimes is a lot of times it is caused secondary to other infections. So most of the time, when somebody gets an ear infection, the first step in getting an ear infection is getting a different infection. Typically some kind of cold or something that is going to cause stuffiness or congestion in the mouth and nose, right? So the last time you had a cold, the major symptom that happens with a cold is stuffiness and congestion. And all that mucus, think about the last time you were sick and how it feels to have, like have you ever had a cold so bad it feels like your face is a solid, like you don't have any, there's no air spaces in there anymore, like everything just feels like it's filled with snot. Well, that's really kind of what happens. And so what will happen is the buildup of mucus and snot from a different infection will basically push that bacteria up into the eustachian tubes. And when that bacteria gets up into the eustachian tube, it can cause infection. Okay, so that's what we mean by endogenous. This is bacteria that already exists within the body. It's just being pushed to an area that's not normal. So it's being forced into the eustachian tubes because of a different infection. So like I said, most people who get inner ear infections like this, it happens because they had a cold or they had the flu or they had something else, they had a sinus infection that forced bacteria, normal bacteria, up into their ear canals where it can then cause an infection. Okay. And treatment for this, these are very common infections. The most common treatments are antibiotics if it's caused by a bacteria, or nothing if it's caused by a virus. These are not typically very serious infections. Most of the time, a round of antibiotics is going to clear it up pretty quickly. Something to keep in mind, though, and I do want to put a blank one in there. Okay, so acute otitis media, we're still talking about acute otitis media, is, just something to know about it, is the leading cause of, I'm going to put ABX, that means antibiotics, ABX, antibiotic prescriptions in children under the age of 5. Okay, so inner ear infections are incredibly common. I have talked about my son and how many infections he had, and that's a pretty common experience for a lot of kids. Having to have tubes put in your ears and having consistent, constant ear infections is a very common experience. This is not a rare experience. It happens to a lot of kids. It's probably happened to at least a handful of you in here. But it is a very common infection in children. And again, it's the leading cause of antibiotic prescriptions for children under the age of 5. Now, even if you were a person who had a lot of ear infections as a kid, it's not a super common infection in adults. It does happen. I've had an ear infection as an adult, but it is much, much, much less common. Most of you probably can't remember the last time you had an inner ear infection, if you can remember having one as an adult at all. Not that it doesn't happen, it's just much less common. So my question for you is why? And there's a couple of reasons. I'm gonna go with, there's 3 reasons. And I wanna talk about all 3 reasons. So who can tell me one? I'm gonna go back to this for a second. Anybody have any guesses? Hmm?
Like adult immune systems are better equipped than children? The immune system?
I can't quite hear you.
The immune system is better.
Yes, so that's part of it. And I'm going to kind of combine that. So one of them is that children have less of an immune system. So in children, especially infants, they don't have a completely developed immune system yet. Their immune system isn't as effective, and they get more infections in general, right? Anybody who has ever been around 5-year-olds knows that you send them to kindergarten, it feels like they're sick literally every other day. It's a battle when you first send your kids to kindergarten. They come home sick all the time. Their immune system hasn't been exposed to a lot of stuff yet. It's worse. And I'm also going to kind of add on to this one, one of my favorite sayings, children are disgusting, right? Children expose themselves to more bacteria. And I think I've told this story before, that my son, to put it in perspective, my son, when he was about a year old, when he was learning how to crawl, literally his favorite activity was licking the floor. You couldn't put him down anywhere, because that would be the first thing he would do, is he would find a piece of naked floor and lick it. I couldn't take him to an airport. It was terrifying. It was his favorite thing. Children are gross. They have no problems sticking their hands in their mouths or their diapers and then sticking it in somebody else's mouth, right? They are gross. And when you get lots of kids together, they do it to each other. And so they're just exposed to more bacteria in general. I don't know the last time I saw an adult, lick the floor. But, so that's part of it. The immune system is worse in kids, or the immune system is better in adults, however you want to look at it. And children expose themselves more. Children are gross. Okay, one more. Anybody? Yeah, it has to do with the anatomy of the eustachian tubes. So in children, the eustachian tube is shallower. Okay, so look at this picture. In an adult, and if you look at the anatomy think about your own head or mine, right? My ears, the bottoms of my ears, are above my throat, right? If I drew a line from the back of my ear to the top of my throat, it's a line down. So when I am standing up, there is a downward motion of gravity from my eustachian tube to my throat. So everything when I'm standing up will drain because it's a downward slope. In children, the way that their heads are built, in order for infants to have to come out of a vaginal canal, their heads have a different anatomy than an adult's. These are like those funny videos. Have you ever seen the videos on TikTok where they make the babies go like this? So if you take an infant, if you go find an infant if you can find one. So like when I go like this, there's clearly a lot of space between my hands and my head. Infants, a lot of times they can't touch their fingers above their heads. Their heads are so big compared to the rest of their bodies. And where their ears are compared to their throats, it's much shallower. So in infants, the ears are almost even with the back of their throat because their heads are so big relative to an adult's. So that shallow eustachian tube means that there's not as much drainage. Okay, if those eustachian tubes go straight across, right, there's not going to be as much gravity helping them. Okay, so the anatomy of the eustachian tube, the fact that the eustachian tube in kids is so much shallower really leads to a lot of ear infections because that fluid or mucus builds up easier. Okay, and then the last one is kind of related to the eustachian tube, and it's kind of related to the same thing, is that children, especially infants, do you guys know how many hours infants sleep a day? Newborn infants, how many hours do they sleep? Does anybody know? It's a lot. Newborn infants sleep for like 22 hours a day. By 6 months, they're sleeping, only like 16 hours a day. By a year old, they're on a more normal schedule, but it's still really normal for 1-year-olds to sleep for 10 or 12 hours at a time. If you're lucky enough to have an infant that sleeps through the night. They will sleep through 10, 12 hours. My son used to sleep from 7 p.m. to 7 a.m. every day when he was about a year old. So children in general spend more times on their back. They spend much more time horizontal, right? They can't hold up their own heads yet. They can't hold up their own bodies. So babies and infants spend a lot of time, if they are not sleeping, a lot of times they're being laid on blankets or even being held in somebody's arms. They're mostly flat. And so that compounds with the shallow eustachian tube and means that everything just builds up in their head. I want you to think about the last time you had a cold. And when you wake up in the morning and you have a cold, that's when you feel the worst, right? Because you probably took a bunch of NyQuil, you've been sleeping for 9 hours because you didn't want to sneeze all night. And so you knocked yourself out with NyQuil and you've been sleeping for 8 or 9 hours. And when you first wake up, all that stuff is stuck in your head, right? And then when you stand up, a lot of times you can actually feel it draining and it goes down your throat and it's really gross, but you can feel it coming out. And that's because gravity, simple gravity. When you're standing up, all of that fluid is going to go to the place where it's the lowest. When you spend a significant amount of time on your back or sleeping, things like that, that fluid will build up more. Okay? So those are the 3 major reasons why children are much more prone to acute otitis media than adults. There's 3 reasons. Okay, and again, it is the leading cause of antibiotic prescriptions in children under the age of 5. Typically, these are not very serious infections. If they're not treated, they can be. They can cause deafness if it's not treated, things like that. But for the most part, a round of antibiotics, or not even a round of antibiotics, if it's caused by a virus, they just go away on their own. And there's not usually a whole lot of long-term damage with acute otitis media. Right? So our next respiratory infection is the common cold. So we've kind of talked about it a little bit. But the common cold is most commonly caused by viruses. There aren't really bacteria that cause the common cold. The 2 that I want you to remember are adenoviruses and coronaviruses. Now I know coronavirus has, it's kind of a charged word these days. But there are hundreds of different types of coronaviruses. COVID-19 causes a particularly deadly or worse type of infection. But there are a lot of coronaviruses that just cause a mild cold. But there are many, many different, when we say the common cold, we're actually referring to a group of diseases caused by a bunch of different organisms that share very similar symptoms. The biggest signs and symptoms of the common cold are going to be like sore throat, runny nose, congestion, and sneezing. The biggest thing here with a cold is what there isn't. So when you're comparing the common cold to other respiratory infections like influenza and the measles and things like that, you're not going to find in a common cold. Colds don't typically cause high fevers or chills or fatigue or body aches. Okay, muscle pain. Okay, it can cause a little bit of fatigue, but if you've ever had the flu, you understand the difference between like a cold, I don't feel so great, I'm a little tired, and like fatigue from the flu. Fatigue from the flu can last weeks and weeks and weeks and weeks, and you feel like you can't move your body. The common cold is not usually that severe. Again, common colds are not typically going to have fevers, chills, or body aches. Most of the time, colds are isolated to the respiratory system, sneezing, maybe some coughing, congestion, runny nose, stuff like that, sore throat. Right, so transmission or prevention, this is spread through droplet contact, so through the droplets that are spread when a person sneezes or coughs, or any kind of saliva is spread anywhere. They are typically pretty highly contagious. They can be spread through direct contact like kissing or direct contact with any saliva from a person who has a cold. And treatment for colds is not usually anything. We say supportive care, meaning you treat the symptoms. Right, you take decongestants and things like that to help you be more comfortable, but there's not typically treatment that is going to it's not going to cure you. Viruses are very difficult to cure, and truthfully, if we're being honest, common colds are not usually worth trying to treat because they go away in a couple of days, and they're very, 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 very rarely serious. Common colds are called that because they're common. All right, our next respiratory tract infection is pharyngitis. And if you go back to, I don't know if it's listed on here. I think it is. So if you go back to this picture, the pharynx is right there. The pharynx is the very, very back of your throat. Okay, it's kind of it's right behind where your uvula sits, like just behind where, like your teeth end. It's kind of right back here, where your tonsils are. That's where your pharynx is. It's the very, very, very back of your throat. And so pharyngitis, again, inflammation of the pharynx. If you look at the word pharyngitis, itis, inflammation, pharynx. Pharyngitis is inflammation or infection of the pharynx. And the most common cause of this is Streptococcus pyogenes. And the common name for this is strep throat. Okay. So that's the common name for pharyngitis. Pharyngitis is the fancy name, strep throat is the common name. And it's called that, again, because the causative organism is Streptococcus pyogenes. Now, I know that's confusing, but there are two streptococcuses that start with a P. You have Streptococcus pneumonia and Streptococcus pyogenes. They're two different organisms. So just keep that in mind when you're studying. They're two different things. The biggest signs and symptoms of strep throat or pharyngitis, the biggest one is severe throat pain. If you've ever had strep throat, you know how bad this can feel. And then swelling, specifically with pus. So these incredibly fluid-filled, pus-filled, swollen areas in the back of the throat are very, very characteristic of strep throat. There's not a lot of things that are going to cause this level of pus formation in the back of your throat, quite like Streptococcus pyogenes or strep throat. Another common symptom that a lot of caregivers will tell you, I've never personally experienced this, but there are a lot of like seasoned nurses that will tell you that you can smell strep throat, that it has a very particular smell. It causes a foul smelling breath. Now, the reason that it causes this very foul smelling breath and why strep throat causes so much pus and swelling is because the Streptococcus pyogenes produces an exotoxin, which is the toxin that it releases into the body when it's growing inside of a person. And this exotoxin, for lack of a better words, there are fancy words for it, but for lack of fancy words, it destroys or eats tissue. So if anybody who is in lab, now this isn't something you necessarily have to know, but if you've ever been in lab, what's the hemolysis pattern of Streptococcus pyogenes?
Beta.
It's very, very beta hemolytic. And the reason that it's beta hemolytic on a blood agar plate is because it chews through all of the blood in the plate. Now, if you have no idea what that means because you're not in lab, it doesn't matter. I'm just trying to connect it back. That's not something you have to know for this class. But Streptococcus pyogenes produces an exotoxin that eats through human tissue. And so that's what's happening in the back of this throat. The Streptococcus pyogenes is releasing this exotoxin that is chewing through and consuming the human tissue. And what's left behind is dead tissue and white blood cells that are trying to fight it off, which is the pus. That's what the pus is. And that's why there's extreme swelling and extreme pain. That's why it hurts so bad. It's literally chewing through the tissue in the back of your throat. And that's also why your breath smells so bad, because you have dead tissue in the back of your throat. So it's like decaying, foul-smelling, dead tissue in the back of your throat. Yeah?
How are the bacteria not displaced by everything going down the throat?
How are they not displaced? Because they form biofilms. Yeah, they form little like colonies in the back of your throat. And strep throat on its own, it can be gotten rid of without antibiotics, but typically it is treated with oral antibiotics. There are some people who don't like giving people or don't like taking antibiotics, and it's been shown that it can go away on its own, but for the most part, if you go to a traditional doctor, they will give you oral antibiotics for strep throat. And it is transmitted directly or through droplets, like a lot of these respiratory illnesses. So it can be spread through any kind of saliva contact, whether that's through coughing, sneezing, droplet contact, or through direct contact, through kissing or sharing food or sharing drinks or anything like that. So the next one that we're going to talk about is related to this. So those exotoxins, in a typical case of strep throat, when somebody doesn't have any other issues, what we call kind of an uncomplicated case of strep throat, those exotoxins stay in the throat. And eventually the body fights off the bacteria, or you take antibiotics and the bacteria dies and nothing else happens. But in rare cases, those exotoxins, the ones that destroy tissue, can actually get into the blood and spread throughout the rest of the body, which causes more serious infections. One of those infections is called scarlet fever. So scarlet fever is caused secondary to pharyngitis. And this is what happens when the exotoxins from that strep throat become what we call systemic, which means that they get into the blood and they travel to other parts of the body. So the thing to keep in mind here is that the bacteria itself isn't traveling, it's the exotoxins. So the toxins, the poisons that it is putting into your body get into your bloodstream and travel through the rest of your body. And the key kind of symptoms and signs associated with scarlet fever are, it's called scarlet fever because it causes an incredibly high fever. That exotoxin, it's kind of hard to explain in more simple terms, but it basically messes with the part of your body that is your internal thermostat. If anybody has ever seen Osmosis Jones, I know that's an old movie, but there's a movie called Osmosis Jones about a white blood cell, if you've ever seen it. And they talk about the hypothalamus, and the hypothalamus controls the temperature. And that's all true. So scarlet fever is what happens when that exotoxin messes with the hypothalamus and basically turns off your internal thermostat. And so when I say high fevers, I don't mean like normal high. I mean high fevers of like 107, 108, 109, which can start to cause damage to the host. So a fever that is that high, any fever above like 106 degrees Fahrenheit, will start to cause damage to pretty much every part of your body. It causes your proteins to denature. It can cause organ failure, organ damage, all kinds of different stuff. So high fevers like that, 107, 108, 109, can be very, very, very dangerous. Your body is not meant to be that high of a temperature. So scarlet fever, if left untreated, and if somebody isn't taking anti-fever medications and stuff like that, it can be really dangerous. The other kind of signs and symptoms are a full body rash. And then the one that's kind of particular to this infection you don't really see anywhere else is what's called a strawberry tongue. They call it a strawberry tongue because that tongue looks like a strawberry, right? It's bright red, so those exotoxins attack the tissue of the tongue and cause it to become bright red. And there will also be these weird little indentations in it that literally look like strawberry seeds. And it's all due to that exotoxin getting to the different parts of the body. So the scarlet, or the strawberry tongue, and that those two things, the name scarlet fever, scarlet is because of the red tongue, right? Scarlet, red. Strawberry tongue, red tongue, and then fever because it causes incredibly high fevers. Now, transmission of scarlet fever, it's secondary to pharyngitis. So when people get scarlet fever, it happens because they had strep throat first. Or they had pharyngitis first. And then those exotoxins spread to the rest of the body, which causes scarlet fever. And so very, very severe cases of scarlet fever can actually lead to something called toxic shock syndrome, which is when you have so many toxins in your body that your body basically shuts down, without going into too much details. And so scarlet fever can cause toxic shock syndrome, which can very easily cause death. It causes damage to your kidneys and your liver and your lungs and all of your other organs, and it can cause death. So scarlet fever can be an incredibly dangerous side effect of a strep throat infection. Now keep in mind, very, very few, like how many of you have had strep throat? Like, look, I've had strep throat. How many of you have had scarlet fever? Okay, so not a single person in here. Sometimes we get like one, but I think in all the times I've asked that questions, I've had like 3 people raise their hand. So scarlet fever is a relatively rare side effect. It doesn't happen very often. And toxic shock syndrome is an even rarer side effect of the side effect. So deadly infections from strep pyogenes aren't super common in this context, but they can happen. And they most commonly happen when strep throat is not treated. So if it's not treated, those toxins can get into the blood and cause more serious side effects. Okay? So our next infection is pneumonia. And pneumonia is just kind of a generic term that we use to describe a group of infections that cause basically a buildup of fluid within the lungs. That's kind of what defines pneumonia. Pneumonia is inflamed and fluid-filled air sacs. So like you can kind of see here, normal alveoli are air-filled. They're little air sacs that fill up like balloons, that fill up when the lungs inflate and deflate. And they're meant to be air-filled because that's where oxygen gets in and out of the bloodstream. In pneumonia, those air sacs are filled with pus, they are inflamed, and this can lead to impaired air exchange. So if these air sacs are filled with fluid that oxygen is not going to be able to get in there, and the oxygen is not going to be able to get into our bloodstream. Okay, so again, pneumonia is just a generic term that we use to describe a series of infections that have the same symptom. They have this buildup of fluid and mucus and inflammation in the alveoli. Like I said, the air exchange becomes impaired, and patients can experience distress. It can cause difficulty breathing. It can be potentially fatal, but it really depends on the person. It depends on the person, their immune system, the severity of the pneumonia, the type of bacteria, how easily it's treated, right? There are a lot of factors that go into how serious or not pneumonia is. For example, you hear pneumonia, and a lot of times that sounds really, really scary, and it can be, but, my very healthy 9-year-old had pneumonia after the flu last year, and everybody was very unconcerned, right? They put him on a dose of antibiotics, they sent him home with a nebulizer, he was fine. He was fine in 2 days. Nobody was concerned. He had a tiny little spot of pneumonia on one of his lungs. He was healthy, his immune system was working, and he responded to the antibiotics, and so it wasn't a scary, deadly thing. However, an 80-year-old who gets pneumonia doesn't have as great of an immune system. They're not typically as healthy, and pneumonia can be a more devastating illness in somebody who is immunocompromised or older and immunocompromised. Okay, so the severity of the pneumonia is really going to depend on the patient and the type of infection they have and the severity of the infection that they have. But pneumonia can range anywhere from relatively mild and requiring a couple days of antibiotics and a saline nebulizer, or it can be deadly. It can cause permanent lung damage, and eventually the lungs get so damaged that they cannot do oxygen exchange at all. They will become permanently damaged, and the person will die. So there's a huge range of pneumonia. And pneumonia itself is caused by many, many different types of bacteria and viruses. And it's also a secondary infection for a lot of other illnesses. And so we're going to talk about some of these particular types of pneumonia individually, but again, pneumonia is just kind of a generic term, and then we're going to talk about some of the more specific ones. So this is a picture of pneumonia. So if you don't know how to read an x-ray, if you've never seen one before, x-rays, when you have air-filled portions of your body that are just tissue, you're supposed to be able to see through them, right? We typically use x-rays to see the solid parts of our body, right? That's where you see your bones, right? The solid parts. Tissue and things like that are supposed to be see-through. So this side of this x-ray, this is a chest x-ray, is normal. And you can see this is the person's spine, and these little kind of white lines right here are their ribs. That's their collarbone right there. I think that's one of the arm bones right there. But this is normal. The lung part is completely see-through because there's no, except for where the ribs are, there's no bones in the lungs. And so you can see straight through it because it's filled with air. It's a relatively thin tissue. You're supposed to be able to see straight through it. This is your heart, or the heart right here. You're supposed to be able to see straight through your lungs. This side, notice this portion of it right here that's very white. This is the infected portion. And it looks like that because all of those alveoli are filled with fluid and they become inflamed and solid. And so it becomes white. It makes it so you can't see through where you're normally supposed to be able to see through. Okay, so this patient particularly right here has pneumonia only in one lung so far. I don't see any pneumonia, maybe a little bit right here. Kind of hard to tell. I'm not an expert at this by any means, but they have one very obvious portion of pneumonia. The other lung looks pretty normal to me for the most part. But there is a term that can be used, and if you ever watched like medical shows, you've probably heard this before. But there's a term given to very, very serious pneumonia called whiteout pneumonia. And what it's referring to is when you look at a chest x-ray and their lungs are completely white. They've been whited out like a blizzard, right? So they're completely white, which means that the entirety of both lungs is completely filled with fluid, which is obviously a much more serious case. Okay, so these are some of the causative organisms of pneumonia. Again, keep in mind that it can be caused by all different kinds of bacteria, all different kinds of viruses. These are the ones that I'm asking you to remember. Now, these first three, these should all be pretty easy because they all say pneumoniae in the name, right? You just have to remember the first part. But they all say pneumoniae. They are all bacteria. And these two right here are viruses. SARS-CoV-2 is COVID-19, COVID, and influenza is the flu. Again, Streptococcus pneumonia, Mycoplasma pneumoniae, and Klebsiella pneumoniae are all bacteria. All of these bacteria and viruses are known to cause pneumonia. Now, transmission of pneumonia really depends on the bacteria. Depends on the infection that's happening. One of the ways it can happen is endogenously through that NRF, the normal respiratory flora. Like we kind of already talked about, the Streptococcus pneumoniae, we talked about this on the acute otitis media slide. It's part of the normal respiratory flora. But Streptococcus pneumoniae is really only supposed to be in your upper respiratory tract. So if that bacteria manages to make its way down into your lungs because you're sick or any other reason, that can cause pneumonia. It's taking bacteria from where it's normal, part of the normal flora, and doesn't cause any issues, and moving it to somewhere where it's not supposed to be. Okay, and that's what an endogenous infection is. It's taking bacteria that's already in your body. Remember, endo means inside, endo in. Taking a bacteria that's already inside your body and moving it to a place where it's not supposed to be. That's what endogenous means. You can also get pneumonia from droplet or direct contact, especially these viruses. Influenza, the flu, COVID-19, they are known to cause pneumonia, and those are spread through droplet, again, sneezing, coughing, things like that, or direct contact. And then another way that it can happen that you may not have thought of is through ventilator-associated pneumonia. So pneumonia is something that's very common when a person is put on a ventilator, because a ventilator, for lack of a better term, is basically just a tube shoved down your trachea into your lungs that forces you to breathe. And so a person is put on a ventilator when they are not capable of breathing on their own. Their muscles aren't working, they're in a coma, they've gotten some kind of infection that's caused lung trauma, lots of different reasons. But a ventilator is a tube that gets forced down the trachea into the lungs and basically inflates and deflates your lungs to make you breathe by a machine. Now, as we've kind of talked about throughout this whole thing, whenever you introduce something that doesn't belong to your body, you are introducing bacteria. It doesn't matter how sterile you are. It doesn't matter how cleanly the procedure is done. There is always going to be bacteria. And taking a tube that exists on the outside of your body and pushing it to a place where there's not a ton of bacteria is always asking for an infection. And ventilator-associated pneumonia is incredibly common. Most of the people who died of COVID, I don't know numbers on it, but I would say most of the people who died of COVID, especially in 2020, it was happening because their lungs were shutting down because of the virus, and so they had to be ventilated. So they would be put on a ventilator to help their lungs try to recover, but the process of being on a ventilator for 2 weeks or 3 weeks or 4 weeks gave them bacterial pneumonia because they had a tube shoved down their throat for 4 weeks. And that's just asking for an infection. So anytime you have an outside implement put into your body, whether it's a simple injection, you're getting a vaccine, or you're getting a catheter inserted into your urethra, or you have a chemotherapy port inserted into your aorta, or whatever it is, any kind of outside implement that is put into a body is going to be a method of introducing infection. It's creating portals of entry, basically. It's like a direct highway straight from the outside to the inside of your body. So ventilator-associated pneumonia is incredibly, incredibly common. All right, so our next respiratory tract infection is called whooping cough. And so now we're kind of getting into the more specialized ones. We have whooping cough. And whooping cough is caused by Bordetella pertussis. Whooping cough is also commonly known as pertussis. That's kind of the fancy name for it, is pertussis. Its common name is whooping cough. So if you can remember that it's called pertussis, it is caused by the bacteria, this is a bacteria, Bordetella pertussis. And Bordetella pertussis, its biggest symptom is right in the name. It's called whooping cough because the biggest symptom is this thing called a paroxysmal cough. And a paroxysmal cough is a specific type of cough that makes a whooping sound. And the reason that that happens is because the coughing associated with whooping cough is very, very uncontrollable. It's basically muscle spasms happening in the diaphragm. And so what happens is somebody coughs so severely that it feels like, have you ever fallen on your back and gotten the wind knocked out of you really bad and you're trying to suck in a breath and it feels like you can't? That's what this is like. It's like having the wind knocked out of you. So when they breathe in, the whooping sound comes from when they're finally able to get a breath, they go, and they suck in air, and it sounds like a whoop. That's why it's called a whooping cough. I will spare you the sound. It's a horrific sound, especially because it is most common in very tiny babies, and it's very upsetting. But if you want to know what it sounds like, you can Google it. There's sounds on the internet, but I try not to expose people to it because it's very upsetting. But again, the biggest symptoms associated with whooping cough are these prolonged, repeated, and violent coughing episodes. A lot of times they're completely uncontrollable. And it's less like coughing like a normal cough and more like spasms in the diaphragm that are causing this uncontrollable coughing. Now, this infection, is these prolonged, repeated, violent coughing episodes can be so severe that they cause vomiting, like your diaphragm is spasming so hard that you vomit. It can also cause exhaustion due to the prolonged coughing. Imagine coughing so hard and so long that your body is just exhausted. And whooping cough can be contracted by anybody. However, in adults who get whooping cough usually have a very mild infection or no symptoms at all. So adults that get whooping cough, most of the time, they think that they have a regular cold. They don't realize that what they have is something more serious. They have a little bit of a cough. They have very mild symptoms. They might not have even any symptoms at all. However, the people that are most affected by whooping cough are infants. And infants are the ones that are going to experience most of these symptoms. And especially in infants, again, just to kind of put into perspective how violent these coughing fits can be, is that infants, especially because they're so tiny, have been known to cough so hard that it can cause vomiting, it can break ribs, and it can tear holes in the diaphragm. So it can tear holes straight through the muscles of their diaphragm, break their ribs. That's how violent these coughing fits are. So it's not just a regular cough, it's a particular type. And one of the reasons that this is so dangerous is because Most adults in general are smart enough that if they had uncontrollable coughing fits, they wouldn't go hang out with a newborn. However, it's very, very easy and very, very possible for an adult to be carrying this bacteria and have no idea. They might have a little tickle in their throat. They might say, I have allergies. They might not have any symptoms at all. But if an infant is exposed to it, it can cause big, big, big problems. It can be deadly in infants. If not deadly, it can cause permanent damage to the lungs. It can cause, like I said, it can rip holes in the diaphragm, which cause permanent damage to the diaphragm. It can break their ribs, things like that. So this is why the prevention of whooping cough is through the DTaP vaccine. So it's the P, the pertussis, P for pertussis. It's the P part of the DTaP vaccine. The T was tetanus, which we already talked about. And then I don't think we're talking about diphtheria. But diphtheria is the other one. But I don't think we're talking about it, which is fine. But the DTaP vaccine is if you go to, that is why if you are pregnant or you are a person that is going to be around newborns, it's typically recommended that you get a booster to your DTaP vaccine. If you go, again, to a traditional doctor, an OBGYN, for the most part, they are going to recommend that anybody who's going to be around your newborn get a booster for the DTaP vaccine, no matter how long it's been since your last one. And if you're a person that has like multiple kids in a couple of years, they will recommend that you get one every 2 years, just because whooping cough can be so dangerous. And again, it's not always somebody being a jerk and coming around a newborn baby sick. They may not have any idea that they have it. So it's not always about, well, don't go around the babies if you're sick. Like, yeah, that's obvious, but sometimes people don't know they have it, and it can be really, really bad for newborns. So that is why if you ever have a baby or a partner of somebody who's having a baby, my husband had to get it. I'm a psycho about vaccines, as you can probably all tell. So I made all of my in-laws, I made my parents get their DTaP vaccine. No, my baby was born November 30th, so he was right in the middle of flu season. And so nobody was allowed in my house unless they had all their vaccines. But that's personal choice. But that is what the doctors will recommend, is anybody who's going to be around your infant, get a DTaP vaccine. And treatment for whooping cough is antibiotics. Thankfully, most infants who get this, most people who get this, if they are treated, they do survive. So it is survivable. It's not the kind of thing that's deadly all the time. It's just really distressing, and it can cause permanent damage. Sometimes. Yeah, that's whooping cough. Pertussis, Bordetella pertussis. Our next one is tuberculosis. And tuberculosis is another kind of easy one to remember. The causative organism is a bacteria known as Mycobacterium tuberculosis. Now, Mycobacterium is kind of an interesting bacteria. And one of the reasons that it's interesting is Mycobacterium does not have peptidoglycan in their cell wall. So most bacteria we've talked about have peptidoglycan in their cell wall, right? They're either gram-negative or gram-positive. They have either a thick layer or a thin layer, but they have some amount of peptidoglycan in their cell walls. Mycobacterium don't. So they have something called mycolic acid in their cell walls instead of peptidoglycan. And that mycolic acid is a very waxy substance. So what that means is Mycobacterium tuberculosis is very, very good at hiding inside of our bodies. It's very difficult for a human body, a human immune system to fight it off because that mycolic acid cell wall is incredibly waxy. And that waxy, fat-based cell wall means that it's really difficult for immune cells to even see it. It's kind of like it's wearing a cloaking device. It's its invisibility cloak. Being covered in a waxy, fatty substance means that the immune system can't see it as well. It makes them capable of forming these little little walled off sac. So what can happen with the Mycobacterium tuberculosis bacteria is it can get into the human lungs, and it basically forms a little fortress inside of the alveoli in your lungs, where it walls off one of the alveoli, and the bacteria will just stay in there and grow 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 until there's lots of it, and then they break open and distribute and cause chaos. Okay? And because of this waxy cell wall, it also makes it incredibly difficult to treat, which we'll talk more about in a second. But signs and symptoms of tuberculosis, early symptoms of tuberculosis are going to be very similar to the flu. Okay, you might have a fever, fatigue, a little bit of coughing, nothing really specific. But as the tuberculosis consumes the lung tissue and takes over the respiratory system and the lungs, it will start to cause much more serious symptoms. The kind of hallmark symptom of tuberculosis is bloody sputum, so coughing up blood. If anybody's ever seen Moulin Rouge, spoiler alert, Satine dies from tuberculosis, and there's that scene where she pulls the handkerchief away from her face and she's got blood in her handkerchief. That's the hallmark symptom of tuberculosis, is the coughing up blood. The other things associated with tuberculosis are weight loss and night sweats. And tuberculosis, to kind of put it in perspective, tuberculosis used to be called the consumption, if anybody knew that. It used to be called consumption or the consumption, and it was called that because people appeared to be consumed from the inside out. They appeared to just waste away. Before people knew that bacteria existed, they thought that consumption was like a karmic kind of thing, like you did bad things in another life, or you did bad things in this life, and so you were being consumed from the inside out by your bad thoughts and your bad actions. And people just seemed to waste away. They lost weight so fast that it just felt like their whole body was being consumed. We had a patient when I worked at St. Francis who had tuberculosis, and he had come in and he had lost, to put it in perspective, he had lost 100 pounds in 3 months. So that's how severe the weight loss is. It's incredibly fast, and it can be incredibly dangerous. And the other thing about tuberculosis is that it's a very long-term illness. So because that bacteria can basically set up a little fortress inside the lungs, it can sit in there for decades. So a lot of times people won't even have symptoms for many, 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 many years. And then it slowly consumes the inside of the body until the infection takes over and they die. Transmission is through long-lasting aerosols. So tuberculosis is one of those things where somebody can cough into a room and tuberculosis will float around in the air for hours afterwards. So somebody with tuberculosis can cough into the air, they can leave, somebody else can come in 3 hours later and get tuberculosis from that. It's incredibly contagious. There are vaccines for tuberculosis, but for the most part, they're largely ineffective. So there are vaccines. We don't get them in this country because tuberculosis isn't as much of a problem here. If you are from another country, I know we have a lot of students at Tech who are from Nepal and other Asian countries, Indian Asian countries and places like that, where they get tuberculosis vaccines. And so a lot of people at Tech are from other countries, and they have had tuberculosis vaccines. But if you grew up in the U.S., it's not as common. Treatment for tuberculosis, this is one of those things, because of this mycolic acid cell wall, treatment for tuberculosis is very long-term antibiotics. So a standard course of treatment for tuberculosis starts at 6 months. So if you get tuberculosis, you will be put on multiple antibiotics for at least 6 months. Sometimes those treatments can go on for years. Because of that waxy cell wall, the antibiotics have a really hard time getting into the bacteria to kill it. Okay. So tuberculosis is one of those infections that we don't think about a lot anymore in this country because it's not as dangerous. here. And the truth of it is that in this country, we have really good access to the medications that cure tuberculosis, right? I could get tuberculosis and go to my doctor, and I could get a full course of antibiotics for 6 months for $50, right? I have really good access to those medications. Somebody would prescribe them to me, I'd get them, and I would get better. And so in the US, there's not as much of a stigma, and it's not as much of a thing. But in other parts of the world, that's not true. There are parts of Africa and other Asian countries and things like that. Africa is not an Asian country, but Africa and Asian countries where tuberculosis is still a huge problem. And there's a really cool book, if anybody's interested in it, I think it's a cool thing to read. It's by John Green. It's a book called Everything is Tuberculosis. And it talks about a lot of this, and it talks about a lot of the social things that go into tuberculosis and how it's become largely, like, again, and this isn't meant to be a shamey thing because I didn't know about it either, how largely in the US we don't think about it. We don't think about it as an issue. We think about tuberculosis in terms of like Moulin Rouge and Satine and in France in the 1800s, right? We don't think about tuberculosis now. But the truth is that tuberculosis is still, to this day, as of right now, the world's most deadly infectious disease. It's still the most deadly infectious disease. There were only 2 periods in all of history where tuberculosis did not rank number 1 in deadliness. The first one was during the Black Plague in the 1300s, and the second one was during COVID for 2 years. But then tuberculosis took back over in like 2022. Okay, so tuberculosis, and the crazy thing about that, and this is like the kind of takeaway from this book, which is, it's an interesting thing to think about, is that his kind of thesis statement is we are currently choosing to live in a world where the most deadly infection in the world is curable. We have the antibiotics and the drugs to cure it, and we've had those since the 1980s. We've had them for 40 years. It is a curable infection, but still, we are choosing to live in a world where it is still most deadly infection. And a lot of that has to do with big pharma companies. Pfizer holds the patent to those vaccines and drugs, and people in other countries don't have access to them, or not affordably. So it's just something to think about, something to be aware of, just being socially aware in the world. And again, this was something, I actually just read this book recently, and this was something I had no idea about. And I have spent my entire adult life, I used to check people, I used to test people for tuberculosis all the time. Like, I've spent my adult life as a microbiologist, and I had no idea. So it's just something to open your eyes to a little bit, something to think about. Even if you just read the synopsis of the book, it is a good book. But yeah, tuberculosis, again, it's just the idea that we are currently choosing to live in a world where the most deadly disease that we have is curable and has been curable for 40 years. And that's a wild thing to think about. Okay, so I think we'll stop there. We'll do the last couple of slides next time before we finish